We've already talked about one obstructive lung disease. That was asthma. Now we're going to talk about the other one, COPD. What I want to do is refresh you on the obstructive lung disease in general, talk about COPD diagnosis and management, go over sort of the global treatment of COPD, and then focus on COPD exacerbations. Let's start off by talking about obstructive lung disease in general. In the spectrum of your life, there are two major time points: becoming an adult and getting old. And I use this to illustrate the fact that obstructive lung disease exists on a spectrum. But primarily, you're going to make the diagnosis of COPD in adulthood, whereas you'll make the diagnosis of asthma as a child. Now, someone can have asthma later on in life, but they're likely to be diagnosed as a child, whereas someone who has COPD will be diagnosed in adulthood. Now, could you get COPD younger than 65? Of course. But the idea is you have to have a combination of both genes and environment over a long period of time. And when I say environment, what I mean is smoking, illustrated by the fact that almost all COPDers are smokers, but not all smokers are COPDers. And of course, you can get COPD without smoking if you have some other form of exposure. What you should be looking for in somebody who you think has COPD is someone who has obstructive lung disease, smoked a lot, and is a little bit older. And COPD really is a combination of two diseases: emphysema and bronchitis. The normal lung consists of a bunch of alveoli, much like a bunch of grapes. They do this to increase the surface area to allow for adequate gas exchange. In emphysema, you have the breakdown of alveoli, and what you end up with is not as much surface area. On the emphysema side, what that means is you have CO2 retention. With CO2 retention, you don't have any change in oxygen. So you have no cyanosis, no hypoxemia. And resistance takes time to overcome. So what you'll see is people actually pushing air out of their lungs. You do that by increasing the intrathoracic pressure, contracting your abdomen and your intercostal muscles. So you'll see an increased AP diameter as the chest hypertrophies. And because it takes time to overcome resistance, you'll see a prolonged exhalation. And they will breathe through pursed lips. It is the combination of the pursed lips and the absence of cyanosis that gives these characters the name pink puffers. Whereas on the other side, bronchitis, you have inflammation of the airways, which leads to decreased oxygen, which leads to cyanosis, hypoxemia, and cyanosis. Decreased oxygen in the lungs causes vasoconstriction. Vasoconstriction increases the resistance in the pulmonary arteries, leading to pulmonary hypertension. Pulmonary hypertension leads to right heart failure, which really means edema. And it is the combination of the blue color of cyanosis and the edema that gives this side of COPD the nickname blue bloaters. In general, most patients are a combination of the two, where one characteristic may predominate. Most of the time, it's both. So if you see somebody who's got obstructive lung disease and has elements of emphysema and bronchitis, you want to make the diagnosis. The only way to make the diagnosis of COPD is with pulmonary function tests. And because it's an obstructive lung disease, as we learned in asthma, you'll see a decreased FEV1 over FVC. And the worse the FEV1 is, the worse the COPD. But unlike asthma, there is no reversibility. So you should not be ordering a methylcholine challenge. Now, COPDers are going to present with shortness of breath and maybe some wheezing. So you might think that tests like the chest x-ray, ABG, and EKG are good places to start. They are in a COPD exacerbation because you want to make sure it's not something else. And while a chest x-ray may show a flattened diaphragm, it's not specific or sensitive for COPD. While we know the CO2 retainers of the emphysema side might show an elevated CO2 but a normal pH, that's not useful for making the diagnosis of COPD. And the EKG is to look at the heart. Remember, diagnosing COPD, pulmonary function tests. I want to set you up with a simplified version for treating chronic stable COPD. Something that you can remember and see in a pictographic form, recognizing that it's harder. So I'll go through it the easy way and expand on it a little bit more complicated and let you read about the complete management of stable COPD if you so choose. To treat, you want to start off with a short-acting beta agonist, as needed. And what's cool is that everything we add on includes the thing before it. So you start off with a short-acting beta agonist, much like you do in asthma, albuterol. But then you do something different for COPD. You're going to add a long-acting muscarinic antagonist. This is tiotropium. You don't do that in asthma. Tiotropium is the first long-acting medication you introduce in COPD. Then you add a long-acting beta agonist, anything that ends in -ol. Notice what we did here. If you remember from asthma, if you put someone on a long-acting beta agonist, they die. You must include inhaled corticosteroids first in asthma before adding a long-acting beta agonist. In COPD, you choose the long-acting muscarinic antagonist and add the long-acting beta agonist next. Only if that doesn't work do you add inhaled corticosteroids. And recently we've added a new class, the phosphodiesterase 4 inhibitors. And if all else fails, you add steroids. And of course, you know your job is to get people off steroids. This is the easy version. Albuterol, tiotropium, any long-acting beta agonist, any inhaled corticosteroid, any phosphodiesterase 4 inhibitor, add steroids. In reality, what you're going to do is be using short-acting bronchodilators, long-acting bronchodilators, inhaled corticosteroids, oral medications, and steroids. Take that framework, let's talk about COPD management on a global scale, which includes medications, and review what I just said there. The mnemonic to remember how to treat someone chronically with COPD is COPDer. Now we're going to take the E first, which is experimental. Basically, it's not working. Some interventional pulmonologists are trying to put valves that are one way to let the CO2 out, let the gas escape. Cool ideas, not something you have to know about. But the rest of them you do. The C stands for corticosteroids. This comes in a number of forms. It's going to be the inhaled corticosteroids, oral steroids, like prednisone, and IV steroids, like methylprednisolone. And you can see this sort of as stable COPD, really bad COPD, COPD exacerbation. The O stands for oxygen. And the way you're able to give someone oxygen is if the SpO2 is less than 88% or the PaO2 is less than 55. And that can be at exertion or at rest. Your goal is to get the COPDers oxygen saturations between 88 and 92. I'll take a minute to explain that. You and I breathe with a hypercapnic respiratory drive. If our CO2 goes up, we breathe faster. Because COPDers retain CO2, they lose that ability. So instead, they are dependent on their hypoxic drive. They must be hypoxemic in order to stimulate their brainstem to breathe. This comes into play when you've intubated someone and had them on a ventilator for 5 days and kept their sats at 100%. You kill their hypoxic drive, so they're very difficult to liberate from the ventilator. And chronically, what you want to do is keep a patient at 88 to 92. But if someone comes in with a condition that's an emergency and their oxygen levels are low, giving them a lot of oxygen in the acute setting will not hurt them. They need the oxygen in the acute setting, give it to them, but then know that once that acute setting is over, scale back 88 to 92%. P is prevention. That exists in the form of two things: vaccines, which is flu and streptococcal, every year, once before 65 and once after, and in smoking cessation. We're never starting in the first place. Smoking cessation and oxygen are the two things that improve mortality. Everything else just makes your life better. But those are the two things that are actually going to prolong life. D is the dilators. And this comes in the form of short-acting, tiotropium, albuterol, long-acting. This is the LAMAs and the LABAs and the orals, theophylline and the phosphodiesterase 4 inhibitors. And R stands for rehab. Rehab can improve overall exercise capacity, but again, doesn't change mortality. So this is how you manage somebody who's got COPD, who's chronic and stable. What do you do when someone comes in with a COPD exacerbation? So someone who's got signs and symptoms of COPD are going to have wheezing, cough, sputum production. Now you want to make sure that this is a COPD exacerbation and not something else. And this is where the chest x-ray, the ABG, and the EKG come in handy. For this discussion, let's just say these things point us towards COPD. All COPD exacerbations are treated essentially in the same way. And whether you do that at home or in the hospital or in the unit, it's basically the same concept. All COPD exacerbations are going to get antibiotics. It's not true, not all of them, but most of the time you're going to give antibiotics because you identify the COPD exacerbation as cough and sputum production. The antibiotics you can pick are generally between doxycycline and azithro. Azithromycin has issues with the QT interval, so get an EKG first. Doxycycline messes up your teeth. Generally, you want to alternate between them. I said everybody, but so you've heard it, not everyone needs antibiotics, but most people get them. What everyone needs are bronchodilators. In the case of a COPD exacerbation, that's going to be done with albuterol and ipratropium. And everybody needs steroids. And steroids come in one of two forms. PO, which generally means prednisone, or IV, which means methylprednisolone. Which one you pick depends on how severe they are. Someone who's having a very bad COPD exacerbation gets IV methylprednisolone and nebulized albuterol and ipratropium. Someone whose COPD exacerbation isn't that bad, or is sort of tapering off at the end, gets oral prednisone and meter-dose inhalers, albuterol and ipratropium. So what do you look for to decide how bad a COPD exacerbation is? What you look for is a response to your therapy. You're going to give them oxygen to keep their pulse ox between 88 and 92. You're going to give them duonebs, which is albuterol and ipratropium, Q30 minutes. You're going to give them steroids. And you say, okay, do you get better? They go home. Do they get worse? Or worse is represented by rising CO2, confusion, absence of wheeze in the absence of lung sounds. That person goes to the ICU. Or do they just need more time? If they need more time, they go to the wards. The person who goes home gets PO steroids and meter dose inhalers. The person who goes to the wards can get PO or IV, but generally PO steroids, and nebulized bronchodilators. The person who goes to the ICU is going to get IV steroids, continuous nebulizers, and either BiPAP or an ET tube. But it's the response to the treatment that tells you where they're going to go and what they're going to get. So we talked about COPD exacerbation, how to identify and diagnose COPD, medical therapy for chronic stable COPD, and then the global therapy for COPD in general, focusing primarily on oxygen and smoking cessation to improve mortality. That's COPD.